Welcome to Clinical Thinking Lab, Episode 5. Today's case is different from the previous episodes. This is not mainly about finding one diagnosis. This is about prioritization under pressure. A patient arrives critically ill, and every consultant is worried about a different emergency. The emergency physician says the GI bleed is killing him. The ICU fellow says, no, this is septic shock. The nephrologist says, if you don't treat the potassium first, you will arrest. The gastroenterologist says he needs urgent endoscopy. And the difficult part is this: everyone is partially right. But if we try to do everything without priorities, we may lose the patient. So today's lesson is: when multiple life-threatening problems happen at the same time, decide what kills first, what can happen simultaneously, and what can wait. This is a 64-year-old man brought to the emergency department with fever for 2 days, progressive weakness, black stool since yesterday, increasing dizziness, and collapse while walking to the bathroom. His past medical history includes type 2 diabetes, chronic kidney disease stage 4, ischemic cardiomyopathy with an ejection fraction of 35%, and hypertension. He is taking aspirin, clopidogrel, furosemide, lisinopril, and metformin. His vitals are very concerning. Blood pressure is 72/40. Heart rate is 124. Respiratory rate is 28. Temperature is 38.9 degrees Celsius. Oxygen saturation is 95% on room air. On examination, he is pale, confused, has cool extremities, melena on rectal examination, and mild suprapubic tenderness. So immediately, this is not a single problem patient. This is a critically ill patient with shock. And the first question is not which specialist should see him first. The first question is what can kill him in the next few minutes. His investigations showed several major problems. Hemoglobin is 6.2. That supports significant upper GI bleeding and poor oxygen carrying capacity. Potassium is 6.8 with peak T waves on ECG. That is malignant hyperkalemia, and it can cause fatal arrhythmia or cardiac arrest. Creatinine is 3.8, up from a baseline of 2.2. So he has acute kidney injury on chronic kidney disease, which worsens potassium excretion and acidosis. WBC is 22,000 and lactate is 6.9. Urinalysis is positive for nitrites, leukocyte esterase, and numerous white cells. That supports urosepsis as a likely source. So the labs tell us that several things are happening at once: severe GI bleed, sepsis, AKI on CKD, malignant hyperkalemia, metabolic acidosis, and shock. This is exactly where prioritization matters. My clinical reasoning is that this patient has mixed shock. There is a hemorrhagic component from upper GI bleeding. There is also a septic or distributive component, likely from urinary tract infection. The AKI on CKD is worsening the hyperkalemia and acidosis. And the hyperkalemia is immediately dangerous because there are ECG changes. So the most likely diagnoses are upper GI bleed contributing to hemorrhagic shock, urosepsis causing septic shock, AKI on CKD, and malignant hyperkalemia. But the key is not just naming them. The key is ranking the immediate threats. Number one threat is malignant hyperkalemia with ECG changes. Why? Because he can arrest in minutes. Then the second priority or threat should be shock from bleeding and sepsis, because without perfusion, he will develop worsening lactic acidosis, renal failure, myocardial ischemia, and death. The third threat is definitive source control and procedures, including dialysis and endoscopy. Once he is stabilized enough, the core idea is treat the immediate electrical threat first while resuscitating the shock in parallel. The first immediate intervention is IV calcium. Calcium does not lower potassium, but it stabilizes the cardiac membrane and reduces the risk of fatal arrhythmia. So, in malignant hyperkalemia with ECG changes, calcium comes first. At the same time, several things must happen in parallel. Obtain large bore IV access, start monitoring, send blood cultures and urine cultures, start broad spectrum IV antibiotics, because this patient has septic shock physiology. Send type and cross match, start pack red blood cell transfusion because hemoglobin is 6.2 and he is in shock. In this patient, blood is not just correcting anemia, it is restoring oxygen delivery and intravascular volume. Then ship potassium intracellularly with insulin and dextrose. Consider nebulized salbutamol if appropriate. Because he has CKD, AKI, hyperkalemia, and acidosis, nephrology should be involved early for urgent dialysis if hyperkalemia or acidosis is refractory. If hypotension persists despite appropriate resuscitation, start norepinephrine to maintain perfusion. Endoscopy is important, but rushing an unstable patient with potassium 6.8, BP 72/40, lactate 6.9, and untreated septic shock directly to endoscopy is dangerous. So the principle is stabilize first, then definitive procedures. But stabilization does not mean delay everything. It means doing the right things in the right order with multiple teams working at the same time. Now the case becomes harder. 15 minutes later, the patient has received IV calcium, insulin, and dextrose, broad spectrum antibiotics. 1 unit of blood is running, and norepinephrine has been started. Then he suddenly develops crossing central chest pain. Repeat ECG shows an inferior STEMI. At the same time, the melena continues. Hemoglobin is still 6.1. Now there is a new conflict. The cardiologist says he needs immediate PCI and dual antiplatelet therapy. The gastroenterologist says if you start antiplatelets now, he may bleed to death. This is not a situation with zero risks. This is a situation with competing life threatening conditions: active upper GI bleeding and acute ST elevation MI. The first important point is that fibrinolysis would be dangerous here because active bleeding is a major contraindication. In ST elevation MI, reperfusion is still important, but primary PCI is generally preferred when feasible, especially when fibrinolysis is unsafe. So, my approach would be activate the cath lab urgently. Do not give fibrinolytics. Involve interventional cardiology, gastroenterology, ICU, and possibly hematology immediately. The anti-thrombotic strategy must be individualized. Completely ignoring the ST elevation MI can kill him, but blindly giving full antithrombotic therapy without acknowledging active bleeding can also kill him. So the right answer is not pretending there is no conflict. The right answer is building the safest multidisciplinary plan. The first teaching Paul is treat what kills first. In this case, potassium 6.8 with peak T waves can cause cardiac arrest within minutes. So IV calcium comes first. The second Paul is resuscitation can be simultaneous. Blood cultures, antibiotics, blood transfusion, potassium shifting, vasopressors, and specialist calls should not happen one by one over hours. They should happen in parallel with clear leadership. The third Paul is procedures need timing. Endoscopy matters, dialysis matters, and PCI matters. But the question is which procedure is safe right now? Which one cannot wait? And what needs stabilization first? The fourth Paul is when treatments conflict, there may be no perfect answer. ST elevation MI needs reperfusion. GI bleed needs bleeding control. Antithrombotics can protect the heart, but worsen bleeding. Avoiding antithrombotics may protect against bleeding but risk coronary thrombosis. So your role is not to search for a magical risk-free option. The role is to recognize the trade-off and coordinate the safest plan. My final takeaway from today is the best physician is not the one who lists the most diagnoses. The best physician is the one who knows what to treat first. This is Clinical Thinking Lab episode 5. One patient, multiple emergencies, one priority question. What will save this patient first? This is the ANC experience. Thank you for watching. See you in the next.